Hi, my name is Dr. Peter Tolosano. I am the Director of Psychological Services for the Connecticut Department of Developmental Services. Welcome to our video on understanding autism spectrum disorder. This video is intended for caregivers, family members, and providers. I'd like to introduce my co-presenters today, Dr. Tracy Sondick and Jennifer Crum.
Thank you, Peter. My name is Dr. Tracy Sondick. I am the Director of the Behavioral Intervention Service at Connecticut Valley Hospital, which is part of the Department of Mental Health and Addiction Services. Happy to be here with both of you.
Thank you. My name is Jennifer Crum. I'm the Director of Autism Services at Beacon Health Options, which is the administrative service organization responsible for authorizations for behavioral health services in Medicaid. As we look at the statistics for autism spectrum disorder and the prevalence, we see a steady increase of diagnosis since 2000. In 2014, the Centers of Disease Control and Prevention indicated the prevalence of existing cases of autism spectrum disorder in the United States is about 4.5 times more common among boys than in girls. As we look at the possible reasons for the increase in diagnosis of autism, we understand that there's a better awareness among mental health professionals, pediatricians, and school professionals who are able to access diagnostic evaluations for individuals who they might think meet the criteria for an autism spectrum disorder. We also look at the new validated measures that are able to diagnose autism, including the Autism Diagnostic Observation Scale, the Gilliam, and the CARS, to name a few. We also look at the increased access to treatments, including applied behavioral analysis, speech therapy, occupational therapy, and school-based services. As these services have become more well-known to parents to advocate for, more individuals are able to access those services. The Department of Social Services has clear regulations and guidelines to help determine who is able to access the services for autism in Connecticut. An individual must have a primary diagnosis of an autism spectrum disorder using standardized tests, as I mentioned before, including the Gilliam, the Autism Diagnostic Observation Scale, and other validated tools. We also look for an individual to be diagnosed prior to the age of 22 years, which is expected to continue indefinitely. So this used to include the PDD-NOS or Asperger's syndrome diagnosis given before 2006 and is now all included under the autism spectrum disorder. We also look for deficits in adaptive functioning in at least 3 of 6 areas as measured by an appropriate instrument, including the Vineland or the Basque. Intellectual functioning above the level of ID, which is an IQ, a full-scale IQ score of 70 or above, is also looked for as part of the criteria to be eligible for in-home services through the Department of Social Services, Medicaid in Connecticut.
When we think about an autism diagnosis, there are 2 core domains to understand. The first core domain is impaired social and communication skills. The second core domain is restricted or repetitive behavioral pattern. However, when we come to better understand autism spectrum disorder, we can see that it is quite a complex array of comorbid disorders that may be associated with it. As depicted on the slide, we may see obsessive compulsive disorder, typically in about 30 to 40% of individuals who have a diagnosis on the autism spectrum, along with other comorbid diagnoses such as attention deficit disorder, social anxiety, as well as some physiological disruptions such as GI issues, sleep disturbances, immune dysfunction, and so forth. The next slide shows how heterogeneous autism spectrum disorder can be. If you look around the slide, you can see there are genetic factors, there are medical comorbidities, there are biological issues related to it, and also clinical issues implicated as well. It has tremendous variability under that umbrella of autism spectrum disorder?
The Diagnostic and Statistical Manual 5, which is the reference that helps us to accurately diagnose and also to be able to code for billing purposes, has made a significant change in this most recent update in 2013. The autism spectrum disorder is now the umbrella or primary diagnosis. As you can see from the slide, autistic disorder, Asperger's, and pervasive developmental disorder, NOS, are now subsumed under the autism spectrum disorder. So those three, Asperger's, PDD, NOS, and autistic disorder, are no longer utilized according to DSM-5. This has been a significant shift, and so as we were talking about the eligibility in earlier slides, the diagnosis in 2006 may include one of those diagnostic categories, but now moving from 2013 forward, the autism spectrum disorder subsumes them.
To underscore Tracy's point, prior to 2013, the umbrella term was not autism spectrum disorder, but it was actually pervasive developmental disorder, not otherwise specified.
So DSM-5 and the Autism Diagnostic Observational Scale, the ADOS-2, has categories that are helpful to understand how to assess and define autism. The ADOS-2, which is the gold standard in terms of diagnosing and understanding a participant's abilities, strengths, and weaknesses, produces one of three results from the assessment. They can be diagnosed with autism. They can be diagnosed with autism spectrum, which again subsumes those previous categories of PDD, NOS, Asperger's, and an additional childhood disintegration disorder. And then it also indicates when someone does not meet the criteria, what we'd say is non-spectrum. So their condition may be explained by another developmental disability, Rett syndrome, Fragile X, just to name a couple of those possibilities. Here you can see on this slide comparisons in the diagnostic changes in autism from the previous version of the DSM-4 TR, and the DSM-5 from 2013. You can see the diagnostic changes, now all subsumed under the autism spectrum disorder, and the different criteria that are needed to be diagnosed with the autism spectrum disorder.
The following slide shows the themes and variations of autism spectrum disorder along a continuum. The arrow to the left, which encompasses about 50% of individuals who carry the diagnosis, are folks who are more severely affected. These may be individuals who are nonverbal or have just basic essential verbal skills. They may have an accompanying intellectual disability. They may have severe limitations in their behavioral profile, and their social skills may be quite compromised. To the right of the screen, we have folks on the higher end of the continuum, and these are individuals who are less severely affected. They have average or higher intellectual functioning, typically very good access to verbal skills. They may have limited social understanding in some situations, particularly when there are stressful or novel circumstances at hand. You may see some motor impairments and some difficulties in fine motor skills, but typically these folks are less significantly affected.
In autism spectrum disorder, we also see individuals who have significant difficulty understanding and appreciating that others may have different thoughts, feelings, opinions, intentions, and plans that are different from their own. They also may have difficulties with intuition, which can result in the following: misreading body language, misinterpreting subtle social cues, problems with give and take, and difficulty understanding expectations. Sometimes there is a painful awareness of social differences and challenges with fitting in socially, and may give rise to episodes of anxiety and depression. This is most typically seen in individuals who are less severely impacted by autism and may also be higher functioning intellectually. Also within the autism spectrum disorder, we see differences in cognitive functioning. Often individuals present with rigidity in thinking and beliefs and convictions or rules. Autism is frequently misassociated with intellectual disability. On the contrary, strong language skills can easily be misinterpreted as advanced communication or social skills, which can lead others to mislabel their actions as purposeful and manipulative. Early intervention is key in treating the symptoms and behaviors associated with autism spectrum disorder and teaching skills to overcome some of the cognitive functioning and rigidity in beliefs and behaviors. Symptoms may not manifest until social demands exceed capacities or may be masked by learning compensatory strategies in adolescence and adulthood. This often leads to diagnosis in school-age individuals once social and educational demands increase. Furthermore, awareness of differences in individuals who are higher functioning might also trigger anxiety and depression as comorbid diagnoses.
So when we are evaluating to determine if someone meets the criteria for an autism spectrum disorder, it's really important to not just understand the diagnosis, but also how it is playing out and showing up for the person, understanding the severity, along with the specific domains that are impacting the person's functioning. The ADOS, the Autism Diagnostic Observational Scale, which we discussed in prior slides, is an interactional assessment measure. Essentially, it creates a social world with the examiner and with the participant to understand how they communicate, how they can problem solve, initiate, and understand different social nuances. It's really important when using any assessment tool that we want to be cautious with our diagnosis and labeling. We know that even normal, typical functioning children will perseverate or overly gesture to communicate or may have diminished eye contact, and that doesn't mean they meet the criteria for autism. Autism spectrum disorder can be reliably diagnosed around age 2. The ADOS actually is, there are formats that can assess even as early as 18 months. If it's a regressed type, in other words, the child had reached a milestone and now is showing regression in their abilities, then you must check with a medical provider first before the assessment. It could be related to another developmental or neurological condition. We know that autism is found across all cultures and socioeconomic groups. The ratio is about 5-to-1 between males and females. In assessing autism, sometimes the diagnosis is formulated later on when the social and communication skills deficits are more apparent. This often occurs when a child may be progressing into elementary school, middle school, or even as late as high school. Delays are an absence of the development of a skill set, but we see some diagnostic overlap with other conditions. For example, language acquisition, being able to express oneself, could be related to an autism spectrum disorder, or it could be a byproduct of an expressive language disability or intellectual disability. So key is doing a thorough neurodiagnostic evaluation to determine the proper diagnosis. The areas for diagnostic consideration for an autism spectrum disorder include language and communication skills, social relationships and responses to social situations. This gets into the nuances of being able to interact, maintain eye contact, understand, as Jennifer was mentioning, theory of mind, being able to understand another person's viewpoint. So these are all areas we're looking at in the social and communication domains. Responses to noises. People that have an autism diagnosis often have an oversensitivity to noises, to stimuli, touching, sights, and other senses. So sometimes environmental responses can be helpful in diagnostic clarification. And also looking at a person's behavior when they're alone and when they're in groups. Does this change? These are all areas that we want to assess and help us understand a person's functioning. And finally, as we mentioned earlier, we want to understand a person's intellectual capabilities. That may not give us a complete picture of whether they meet the criteria for autism spectrum, but it helps us understand their unique profile of strengths and weaknesses.
To reinforce Tracy's point about sensitivity to environmental issues, quite often individuals who carry the diagnosis of autism spectrum disorder have issues around sensory integration. Therefore, as Tracy alluded to earlier, it's important to get diagnostic input from multiple sources, including occupational therapy and family members who may observe the individual across time and situations. When we think about treatment considerations for autism spectrum disorder, it is important to realize that it is a lifelong condition. At this juncture in time, there are no biological tests that exist that fully help us to understand the entire genetic makeup. However, about 10 to 15% of the genetic markers have been identified. If an individual has a younger age, it is much more difficult to differentiate between intellectual disability and autism spectrum disorder. Before, it was believed that about 70 to 80% of individuals who are on the autism spectrum carried a diagnosis of intellectual disability. However, at this point, the number is about as low as 30%. Oftentimes, early interventions help individuals who have an autism spectrum diagnosis acquire language, which most certainly helps them to develop intellectual and adaptive skills. Diagnostics and treatment are challenging because there are both positive, i.e. abnormal, and negative, meaning absence of normal behaviors in a typical autism spectrum profile. As I mentioned earlier, there's tremendous heterogeneity or variability in the behaviors of individuals on the spectrum, between them, and also in the same individual. You may see differences in intellectual level, language abilities, ability to concentrate, and also to regulate one's mood. The overarching treatment goals oftentimes involve helping an individual to modulate their behavior and building their life skills, especially socially. As one can appreciate, having regulation skills and social skills certainly facilitates learning. Also, with regard to treatment considerations, a variety of options should be explored, as no one treatment type will impact all of the signs and symptoms in the same way. It's really important to come up with a package that's tailored to that individual. So, for example, applied behavioral analysis, speech therapy, occupational therapy, and physical therapy may all be combined in an integrated package to assist an individual.
And to add on to what Peter said, that's why it's so important to have a full evaluation so we can determine not just a person's cognitive domains, not just one of the social domains, but to look at the person from a holistic perspective. That aids in a much more effective treatment plan.
I'd like to thank my fellow co-presenters for our work today. We hope you found this video to be informative. Tracy?
Thank you, Peter, and thank you, Jennifer. It was a pleasure to present on this very important topic. This is the second part of a three-part series. Our first presentation was Understanding Intellectual Disability, this presentation, and then our third in the series is Understanding Positive Behavioral Support Planning. So I hope you'll stay tuned for that presentation as well. Thanks.
Thank you, Tracy and Dr. Tolosano. If you have any questions regarding this presentation, please refer to the contact information on your screen. Thank you.